By request of the meeting organizer, this meeting is being recorded.
Thank you, everyone, for joining us for today's end+disparities Learning Exchange office hours on stigma assessment. My name is Michael Hager. I'm the Manager of Technical Assistance at the National Quality Center and the program lead for the end+disparities Learning Exchange. We're really excited to bring you this topic today and to explore some of the stigma assessment tools that are out there that we know about and to see if there are any more that you know about as well. I had a chance to interact with some of you before we started, and I noticed that quite a few new folks have joined the line here. So if we could just introduce ourselves in the chat room, I think that would be really helpful, just to kind of get a sense of who's joined us and from where in the country we're calling from. We might be able to find some connections and some new friends, too, within our own regions that we can continue these discussions in our own settings as we move forward. So let me say Michael Hager, NQC, NY, and disparities lead. And while we're typing in the chat room, I do have our federal partner, Chep Maritime from the HIV/AIDS Bureau on the line. And I'd like to turn it over to Chep just for a moment to provide some words of welcome to you all today.
I want to thank everyone for attending office hours, and Michael, thank you so much. You have been doing such a wonderful job in getting everyone organized and ensuring the success in office hours. I definitely look forward to stigma assessment. Stigma is just really big in our community, and I'm hoping that I can learn from each one of you as to how you've been able to tackle it and what's out there in terms of stigma assessment. What are you using and how successful you have been? I'm just looking forward to the next office hours and a lot of this helpful discussions. Michael, thank you very much.
Thanks so much, Chep, for the supportive comments, and we're also excited that folks have joined us, too. This is one of the larger office hours that we've had to date, and it just shows the importance of this topic, and we hope that we do well by you all and that you all get what you want out of the discussion. In case you haven't joined us before, a little background. The end+disparities Learning Exchange is a 9-month initiative sponsored by our friends at the HIV/AIDS Bureau and run by the National Quality Center. It's all volunteer, and Ryan White HIV/AIDS providers from around the country are invited to participate, and they can be from any part funding. We're trying to create a community of learners where we can rely on each other's expertise and experience to help drive improvements in our own programs and maybe come up with ideas nationally of how we can move forward all together and further reduce disparities in HIV health outcomes. In case you haven't had a chance to see it yet, just a quick teaser for our video. If you go to the end+disparities-exchange.org website, the video is one of the top items. It's a great way to start the discussion with folks at your sites or in your region. In case you haven't seen it yet, I highly encourage you to check it out. If you're also checking out the website, you'll see a link for all the recorded webinars that we've done to date as well, including office hours. This webinar will also be posted within the next couple hours so that you can share it with your colleagues if you find today's discussion helpful, which we hope you will. So what are office hours? Office hours are always on Fridays at 1 p.m. It's a variable schedule, so we encourage you to check the website. There's no registration required, and it's open to all. And unlike our webinars, which are more formal, we mute the lines, there's formal presenters, this dialogue is really intended to be an informal discussion of all of us as peers to think about a specific topic. Today's topic is stigma assessment. Many of you probably know this about me, but I've been living with HIV for now 15 years, and this is an issue that is cross-cutting in HIV services and has been a major roadblock for people and point of frustration for providers for decades, as stigma has lasted and existed as long as HIV has been around. So I am so excited professionally, but also personally, to be exploring this topic with you all, because there has been a huge move in this area over the last couple of years, and many of us might not be aware of this body of work in the field. So without further ado, I'd like to introduce my friend and colleague, Juliaschluter. Julia is an NQC coach who is intimately involved in the end+disparities learning exchange, and she's been working with the National Quality Center for a number of years. She leads Project ARC at the Washington University of St. Louis and is intimately involved in driving programs focused on youth at risk for HIV and youth living with HIV. So she has a lot of experience around the topic and subject matter of stigma and working with vulnerable populations, and I think that she'll do a wonderful job facilitating a discussion with all of you today around stigma assessment tools. Julia?
Thank you so much, Michael, and just thank you to everyone who's joined our call today. It's really exciting to see a number of people who are interested in this skill set, and I think it's really important. We have this open dialogue together. We have some things prepared to share, but really we want to hear from you and hear about and what are you interested in, and what sort of tools have you tried to use to look at stigma or to assess stigma as it relates to quality improvement in your setting. So, but just, before we kind of dive into that, does anybody want to tell me kind of, what stigma, how you would sort of define stigma? Does anybody have any on that? And if you would prefer to chat in the chat room and typing if you're more of a quieter person, also feel free to respond in the chat room. So I certainly want to hear from people kind of what your definition is and what you're bringing to the table in terms of stigma. So any thoughts?
Julia, I received a note that your microphone is cutting out a little bit. It was, and I could hear it cutting out as well. So I just wanted to make you aware of that.
I am working from home today due to this ice storm, so on my cell phone, which sometimes does not have the reception. So, is it any better?
Yes, yes.
Okay, great. So I'll try to talk a little bit closer to the microphone. So, if we think about our work from the NCARE campaign, there were some definitions that were utilized around stigma. And in particular, the researcher, John Fryer, really looked into stigma, and he traced kind of the roots of, where stigma came from in the term. It goes back all the way to the ancient Greek culture. And stigma was used to define people who had, tattoos or scars, or there were branding for slaves, or deserters, or even criminals. And really kind of that sort of cultural association is part of something that was sort of disgraced in the community. And then another definition kind of from the 60s from a researcher, Goffman, has described stigma as a sign or a mark of a bearer who's spoiled or flawed, someone who's fully less than human. And then more recently, in 2000, we have a definition of stigma that's, a bit more, has a bit more construct to it. And it's really looking at kind of two fundamental components, and that is the recognition or difference of someone that's based on a distinguishing characteristic, and also that is a consequent devaluation of that person. And then if we go back to kind of what we've learned from Fryer, we know that he sort of does describe stigma in terms of 4 different types of manifestations. And I'd be really interested once we kind of get these manifestations out to kind of see how you guys, these different manifestations might show up for our consumers who are living with HIV, or in our environment, in our clinics, or our different settings where we're providing services. So first there's public stigma, and that's kind of the social or people's psychological reactions to someone who has that perceived stigma. The second domain or manifestation that is a self-stigma, so how somebody reacts to that possession or association of stigma. Third domain is stigma by association, and that's really how people have different reactions to a group of people you're associated with or a particular person. So if you are associated with that stigmatized person, then you as well as that stigmatized person are grouped into that stigma. And then there's also structural stigma, and this is really the perpetuation of a stigmatized status by policies or society's institutions or sort of ideological systems. So I'm just going to pause there and ask, if anybody is really, seen or felt on any of these sort of domains or manifestations of stigma kind of in their work or experience personally.
Justin actually provided a really succinct, if you collapsed all four of those manifestations of stigma into one definition, I thought that Justin Britannic's description was very succinct.
I think that's perfect. It looks like he said that, stigma is real or perceived designation of a lower worth due to a particular condition. And absolutely, Justin, that's very well said. And I agree. I think that is a nice way to kind of combine all of the thoughts from prior that we've seen in the In-Care campaign work. So, Michael, can you show us how to get to the In-Care campaign's information on stigma?
Absolutely. I was just responding to a point made by Alex, about stigma sometimes being confused or being used concurrently as a term with trauma. And trauma is such an important thing. In fact, our federal partners had an entire consultancy around that. Oops, I'm sorry, that was supposed to be here. Okay, cool. So if you're looking for this presentation in the In-Care campaign, all you need to do is go to events under incarecampaign.org. And as you're looking through all of our past events, you can see a number of different presentations. And I believe that actually would be under, yes, it should be under social services. Yes, Partners in Care, Stigma and Me recording. A great resource, and as you can see, there are many, many resources from our friends within the Ryan White HIV/AIDS provider community, so your peers who have provided content to us, and lots of hours of webinar viewing pleasure for you. You can contact me, Michael, at nationalqualitycenter.org if you have any questions, comments, or concerns about how to find any of these materials.
Thank you, Michael. I also want to point out Delores' note here in the chat room. It says that it's also important to add in self-stigma. And I completely agree. We can't talk about stigma in terms of policies or, our ideological institutions without also adding in that domain. So thank you, Delores, for that comment.
I think that piggybacking on that too, like thinking about Alex's comment about trauma, stigma can be traumatizing, and I think about stigma in terms of like it's almost like a weapon. And Delores' point is like so spot on. There might be all kinds of stuff happening around you, but the damage you do to yourself is far, far more important and more lasting and more impactful than what someone else can say. Probably even on your own mother, like the damage you do to yourself is more significant, I think, in my experience.
Right, and then I think as providers and people who are trying to improve the different outcomes in our different settings for people living with HIV, I think that always then plays into how does that impact retention and viral suppression, and it's such a significant topic, and yet it's so internal that sometimes I think that's harder to try to work on it, or to try to work on with a population of people. So I'm excited today to actually hear from others about if they are trying to work on stigma within their own settings, and kind of, you know, what you're doing in terms of measuring stigma. Has anybody ever tried to measure stigma? I'd love to hear from some folks on the call if you tried to measure stigma, and kind of, have you tried to measure it in terms of your clients, or have you tried to measure it in terms of your setting, your facility? Kind of, you know, what does that look like for you?
I see from Delores a yes, and I saw a comment previously from Sean Oslin about clients wanting to be let in the back door because of stigma concerns. They don't want to be seen by other clients. Sean, I don't know if you could take a moment to talk about this as something where, you know, it was a one-on-one conversation, or was this something that you tried to measure, or after you had these conversations, did you try measuring it? Can you talk us through that a little bit? And you might be muted, sir. Let me see. Sean, I unmuted you. Maybe you can share now.
Yeah, it's just really come up with a couple of our clients independently. They don't want to park in the front of the building. They want to be taken and brought in the back door and go directly to rooms, and it's just, in general, this has not been an issue with clients, but in this case, because of safety and security concerns, we actually had to work with a client and say, listen, this is as safe a place as you'll be, and everybody here is similar to you, and convince the client that they really need to come in the front door, and they needed to be, you know, if the doctor wasn't ready, they're going to have to wait in the waiting room. It's just became too much of a concern after, like, the Pulse shooting and other types of mass killings to really, but to actually make exceptions to our safety rules. So we had to work with the client around this. He adapted, and he was fine with it.
That's fascinating. So it's like a typical kind of response, you know, that we would have to, you know, a one-off.
Yeah. It was a one-off. It's not been. We have other clients have expressed concerns about where, you know, parking in the front of the building where people can see their cars, and we're looking to move offices, and we're looking to have a little bit more, you know, make it not so easy for people to see cars. We're in a small town; it's 25,000 people, and so people know each other's cars, and so it's just, there's no anonymity in a town this small.
Yeah. You know, Sean, I think you bring up a really good point about kind of your environment, and if you're in maybe a larger city or something like that, it might be a little bit easier to sort of blend in, but when you're in a smaller location like that, there might be a different level of stigma because it is that sort of environment in which people know each other's cars, like you said. So thank you for sharing. Delores, I'd love to hear from you, too, about kind of your experience in trying to measure stigma and what that looked like.
So am I unmuted? Because I'm not sure.
We hear you loud and clear.
Can you hear me?
Yes, ma'am.
Okay. So what I wanted to just talk about is what we were doing in New Jersey. And at the state level, we have the New Jersey HIV/AIDS planning group. Part of that, there is a stigma work group. And the stigma work group acknowledges that stigma exists, and that the perception of stigma by providers is different from the perception of stigma by people living with HIV. So about a year and a half ago, we decided to look at the people living with HIV Stigma Index, which originated out of the global network of people living with HIV. They developed this questionnaire. The goal of the questionnaire is for people living with HIV to deliver this survey other people living with HIV so that you get the perspective of people living with HIV over a short period of time, like a 2-year period. So you know, all of us living with HIV, and I've lived with HIV for 23 years, experience a stigma at different levels. But this instrument is really measuring it over, let's say, a 2 or 3 year period, because I think all of us can put stories of experiencing stigma over the duration of the disease that occupies our life, but really to look at it in a shorter frame. And so this particular instrument has rolled out in the U.S. Probably 3 or 4 years ago, first in Detroit, Michigan, then in Baton Rouge, Louisiana. And just this year, we finally got the necessary funding from the state to roll it out in New Jersey. And it's going to be statewide, and we're really looking at a 1% of our population of people living with HIV, and then try to deliver the survey among different populations. The results are not in yet because the project just started. You know, we had 2 training sessions to train people living with HIV as interviewers, and so that project is now ongoing. So I don't have results to give you, but that's the methodology that we're using to assess stigma in New Jersey.
Well, thank you so much, Delores, for sharing that. That was actually one of the tools that we wanted to talk about today to make sure that people were aware of the Stigma Index. So there's a lot of space. So thank you, and it's exciting to hear how, you know, the state, as opposed to a, you know, smaller clinic setting, has really come together to decide to do this across the different Ryan White parks, across different counties. So I think that that's a really powerful sort of statement to the community, in that, you know, this is something that you guys feel like is important and really want to measure and to figure that out. So thank you for sharing that.
Can I take a second, too, just to see? I want to put my fingers on the pulse here. I see Justin from D.C. I see Cher from Washington. I see Shondelyn from Broward. And there are other folks, too, who are from networks, network leaders. And I'm just wondering, you know, would you be interested in potentially trying to create the Stigma Index in your own state, or is this something that you're already working toward in your own state or city?
Hey, Michael, this is Justin from DC, and I was really excited when I got on the call today, just because this is something that we've known is an issue here in DC, but we kind of want a more systematic way to tackle it. And because right now we're redoing some things in our quality program, and we had some initiatives on the Planning Council coming up, like I think this is the perfect time to implement something like that. Just a brief kind of history. I'm sure others can share the challenges we've had, but measuring stigma hasn't been super straightforward for us. We've known for a while that it's a big, huge issue, and it's something that always comes up anecdotally, like when we have focus groups with consumers, and you know, or sometimes we have like grievances, and a lot of it's related to stigma. But when we tried to measure it, starting in 2013 in our EMA-wide satisfaction survey, there was a few questions on stigma, but the responses were a lot, I guess, you know, it kind of minimized the role that stigma played to some degree, kind of what we thought compared to some of the focus groups. So really for us, kind of having some way to square the anecdotal stuff we hear would be really awesome.
Hi, Michael. This is Sherry Levinson in Washington State.
Hi.
And we have been talking about using the U.S. Stigma Index and doing it at a potential statewide level. The funding issues are a little bit peculiar to our state. There's issues around where we may have cash, but we don't have the funding, the legislative authority to spend money over a certain amount. So we're hoping some of that stuff will get taken care of, and we'll be able to start looking at this again in July.
Okay.
We're also been I've been hoping to try to find a clinic who'd be willing to try the clinic or case management agency who'd be willing to work on the work that Laura Nyblade has done with the health policy project, and that is having looking at stigma from the provider behavior, so the clinic behavior, and so it's a slow process because if you're going to ask the providers to identify, it's not necessarily a comfortable thing for them as well.
Yeah.
Unfortunately, I actually have to leave right now.
Okay.
I'm really looking forward to reviewing the chat information, so and any other stuff that you put into the notes of the presentation. So, bye everyone, and I'm sorry.
Bye, Cher. Thanks for joining us, and I'm sorry that you weren't able to join us for the whole time.
Yeah, me too. All right. Bye-bye.
Cheers. Great. Has anyone else had that challenge that Cher had mentioned in terms of, those mundane problems? We have a great process, a great tool. It might even be research or evidence-based, but the funding or some other, silly policy sticking point is preventing us from doing this. And has anyone had any workarounds like that or been successful in trying to get around those roadblocks? I was just curious.
This is Liz over at Whitman Walker. I think I used to work in care navigation as kind of a forward, patient-facing provider, and time is one of the big barriers that we always come back to. Even if we have a new grade assessment, where does it fit into the workflow, and how can we decide what population we're going to be using it in? So just kind of like the implementation piece, and then once you have it, actually getting time to do it with your patient.
True. Okay. I see a couple of lengthy comments have come into the chat room here. One from Tasha that came just to me. I'm Tasha Taylor from Harris County Public Health in Houston. I work with our frontline staff who provide case management services to our clients. We cover stigma in many trainings on cultural competency. I also work with our Ryan White Planning Council members to obtain the voice of the consumer and tap into what our consumers are feeling. So that's really great that you have training, and then you also have those feedback mechanisms to get the experiential piece on stigma assessment in Houston. Have other folks done that type of anecdotal? Have other folks done that anecdotal type of assessment as well? I know Justin said he has.
Michael, this is Julia. In St. Louis, we identified an instrument specific for youth about stigma, and it focused on HIV positive youth, but we had trouble in terms of being able to figure out how to implement it and kind of when to do that amongst the lots of other things that were going on, and to really feel like we were addressing the pieces of stigma that we want. There are lots of different methods out there, but how to kind of create the sort of greatest bang for our buck in terms of the questions that we were going to ask. And so we actually never ended up implementing the stigma tool amongst our youth, but we had lots of questions about that process and what it could look like, and really what our providers felt like were important questions to ask that ultimately would impact start clinic setting for youth.
So I'm just going to switch screens here. Just in case folks are interested in learning more about the Stigma Index, you can go to www.stigmaindex.org, and you can click around. You can see the piece here that Ms. Delores had mentioned about Michigan. This is also being used in other settings around the world, and there are common presentations that happen at major conferences in the U.S. and other places. So you can see the way that the work is described. You can learn a little bit more about this index and the research pieces, methodologically, the ethics, steps to implementation. I wouldn't be surprised if this is where Cher really picked up a lot of the stuff that she's been using to talk with leaders within her state on trying to make this a program moving forward there. I think it's one thing to talk loosely about the qualitative assessments that we have within our own ongoing surveys, feedback boxes, planning council focus groups, all of the great stuff that we have going. But there's something else to be said about being part of something that is kind of, I guess, more macro. You're looking at the same assessment across multiple settings, across multiple populations, and then you can really start to get some really great information on comparability and how you can work together moving forward. I don't know, Julia, if anything else stands out to you, or Delores, if you had any other comments, or if anyone else who's worked on this has any other comments that they'd like to share.
This is Delores. I think what is also equally important is whether you use that methodology or any other methodology is to acknowledge that the perception of stigma is very different coming from providers than from people with HIV themselves, and that we have to reconcile the difference in order to improve our services to meet our medical outcomes that we want, our good medical outcomes that we want.
I think that's an excellent point, and I think that the HIV Stigma Index is a great way to hear from our consumers, our patients, and then has anybody heard of the Dr. Niblade's research on stigma assessment for providers?
No, but I'd be interested.
Yeah, so she works at Health Policy Project, or it's now called the Health Policy Plus. They just rebranded their name. And so it's really just this package of tools that's used to reduce stigma. And I think Michael is going to take us there right now to show us all of the good information that is there that really focuses on looking at and assessing provider stigma. And there's two tools. One is a monitoring tool, and one is this comprehensive brief that has about 20 to 24 questions. And, Dr. Niblade, in her original research, did a literature review of the key questions, and they came up with this comprehensive tool that it has 5 domains to it. So what it looks at is it looks at the infection control, so kind of fear of HIV, the transmission, the behaviors. It looks at enacted stigma, so kind of that self-reported avoidance behaviors. It's at the willingness to treat people living with HIV, and then it looks at the health environment, so like the supplies, the policies, what type of training those individuals are receiving. So it really is a very sort of comprehensive view of measuring provider stigma.
I think that this is a really important piece, and we've had some webinars on this work as well. And Dr. Niblade is just fabulous. She's pretty willing to work with folks who are interested in instituting a project within localities or regions to think about how that can happen. And if you'd like to reach out to me, you're more than welcome to contact me, and I can put you in touch with Dr. Niblade if you can't find her email yourself, and that is michael@nationalqualitycenter.org.
And along with the for the provider assessment, there's also, you can download materials on this website that talk about how to train your staff and what that looks like to reduce stigma for serving people living with HIV among your providers. So there's a lot of great tools there to comb through and kind of think about how that would be best applied in your particular setting. Well, Michael, I'm wondering too if we could show another tool, if that was like, if you wanted to show maybe like the EETC has this video about rural stigma and people living in rural America. That might be another one to kind of check out for people too. We really wanted to just introduce some resources to everybody for measurement, but also just for things you can go to show to consumers or to your providers or different leadership within your agency.
Well, one of the items that I thought was really neat about this video is that it is available with Spanish language closed captioning, because I think that when we're thinking about stigma, we need to think about everybody. And sometimes our lack of Spanish language materials accidentally excludes a large number of people who we're trying to help here. And so having something available that we can, use to, talk with our Spanish speaking folks, I think is really important. I'd like to point out too that there's, it's really great that the AATCs are involved in this level of work around stigma assessment. This particular resource was put together by the National Coordinating Resource Center right across the river from us in Newark. And they're building quite a bit of knowledge and expertise around this. And for folks who don't know, the NCRC is kind of like the umbrella of all of the other AATCs. So work that's happening at this national level for the National Coordinating Resource Center are things that you can probably inquire about your local, with your local AATCs and see if there's a way that maybe, there's a ball that you can get rolling in that way. One of the things that Julia had mentioned, just moments ago, but I mentioned before we started today's office hours, is that there's been a lot of work recently in the last couple of years around stigma assessment and stigma measurement and, stigma projects. But a lot of these things, like what happens, there's a great idea in the center and then everyone kind of goes in their own direction, and there's very little coordination for this really important work that's happening nationally. And we would really like to help use this office hours as a way to introduce many of you to all the different work that's happening so that we can have a conversation about, what makes sense to you and for your clinic populations, so that this initiative can help you think about stigma assessment for all the populations we serve over the next couple months. So today is not going to be the last office hours that you see on stigma. In fact, we're going to be kind of revisiting this as we become more familiar with these materials, as we become more experienced in talking about stigma and in measuring stigma.
Thank you, Michael. So I'm just wondering, since we have about 20 minutes left in our call here, if there are that people would like to share or questions to our list today that you want to throw out to the people on the call, because there's a large group of people here. And so let's just start there and kind of see if there's something in particular or measurements of stigma, or if there's something that you want to just ask the group. So feel free to go ahead.
So this is Delores. So one of the things that I've experienced in my community talking about stigma is that as a public health, I have an understanding of what stigma is. I remember I was in a group of women, community women, and I just started to talk about stigma as if everybody in the room knew what I was talking about. And what I found out was that some people didn't have a clue what I was talking about. And so I had to start sharing examples. And then people were like, oh, yeah, I've experienced that. That has happened to me. And I think one of the things we need to be conscious of is how we use the term, and that we really need to sometimes break the term down so that it relates to community members so that we can get a really true picture of our assessment. And that's just one of the things that I've experienced as I do this work.
Thank you, Delores. I think that's such an important point. And something that, you know, as quality improvement leaders in our own agencies, I think we have to break down a lot of the definitions and the things that we talk about on a fairly frequent basis. So that's just, it's another important reminder to really make sure that we're asking the right questions, but doing it in a way that we will get the information back that will really help us kind of reshape and change the things that we're trying to make better. So thank you for sharing that. Other thoughts?
Does anyone feel invigorated having seen these tools, or have we seen these tools before and we have a whole bunch of questions that we're sitting on? Because we want to make sure that those questions get out into the ether and then we can kind of process them together. We're all learning together, I think, but if this is something that you've already seen and you're a little bit further along, help us out here. Is anyone interested in collaborating moving forward on a stigma assessment project? And what would that collaboration look like? Would you be interested in working with other clinics in your area, or would you think that an affinity around the lines of population is more important than geography, or what are some of your thoughts here? How can we help each other out?
You know, Michael, I see from Justin about how the tools are actually being applied by different people in different programs, and you know, how also we can go beyond the measurement of stigma, because and Justin says, and I agree, Justin, it's difficult to address because it's tied up to the social determinants of health.
Mm-hmm. So what I just posted here is from the University of Alabama, Birmingham. This is kind of the next step after doing Dr. Nyblade's assessment in terms of what you can do to address provider stigma. I believe that this workshop involved items that were focused on providers, and I think that there were some that were focused on consumers as well. Community participants, pre and post, health workers pre and post. So this is a great example of something concrete as an intervention that has been put in place in international settings and has been adapted for use in Alabama. It's called Project Fresh. I'm wondering if anyone else has other examples, or Delores in particular, if you have examples, could also be from the international setting on the Stigma Assessment Index. And what types of projects people have to ameliorate the stigma that's identified.
So I'm glad that you have the website up, because from all the countries that have entered the Stigma Index, the Stigma Index is also an intervention tool, really using the results to develop interventions. Mm-hmm. And on the website, there are some examples of the interventions that have been developed. So in New Jersey, where we're just implementing the tool, what we're hoping to do is from that result is to develop either a toolkit for our providers to improve issues of stigma in the provider setting, or to develop some kind of educational awareness tool for the community. But we are waiting for the results before we develop those. But really, and keep in mind that just the action of training community members on basic research method is in itself an intervention. So, so those are kind of the steps we are planning to take around this initiative.
For those of you who don't know, Ms. Delores, in addition to being, you know, a personal friend and a colleague, she's been working with AIDS Institute for quite some time and in New Jersey for a very long time. She's actually one of the main folks involved in a lot of international activities as well. And I think, Delores, you were involved in helping to create and to spread this from its very beginnings, right?
Yes, so
you're the woman to know.
I've been a long member of the Global Network of People Living with HIV, which is a national organization with headquarters in Amsterdam. I'm also currently on the International Steering Committee for the International Community of Women Living with HIV, another global network with 10 regional affiliates. And we all work together at the global level to continue to spread meaningful involvement of people living with HIV in issues that impact our lives. And the Stigma Index is one of those initiatives.
You know, I had first heard about this work, I think by watching one of these videos here. I don't know, maybe I'm too much of a millennial, but I love videos as a way to kind of share and get people excited or thinking or talking about these issues. That's one of the reasons why we always produce videos for our large national voluntary learning exchange campaign type deals at the National Quality Center. But, you know, I would highly recommend that you visit the website and take a look at these videos. It might be a way to share with people and to get them thinking and get them excited about stigma assessments as a bold, bright new day. This is not something that we need to continue thinking of as, you know, we're helpless. This is just what it is, and it'll have to stay that way. But this is something that we can actually sink our teeth into. You know, I highly encourage you to take a look at these videos.
I think in terms of another resource or tool that has some really great imagery and also some information that's really client-focused, and you know, how to best provide less stigmatized services or hopefully stigma-free services for young Black MSM community is through hishealth.org. I don't know if you can go, but the images are just beautiful. If we're trying to kind of pull people into that conversation, much like you said before, about showing a video, kind of, you know, pulling a little bit more at that sort of emotion decision-making, maybe the sort of head decision-making to begin with, that this was a really great resource for that. And I think that there's things for providers on this website, but there are also things specific to patients that could be really helpful in thinking about, you know, what are some things that I need to do, and you know, what are some sort of, there's a list review, there's a mapping. I mean, I was just really impressed with this resource when I was looking through some things on stigma. So it's just another tool for people to kind of think of they begin their or their.
This is the twin resource to His Health called Well Versed. You know, and I agree, Julia, that the tools and the resources here are very, very, very professional, very well polished. It feels like they're yeah, it's just very beautiful, and I highly encourage folks to take a look at that. Okay.
You know, Michael, Alex has been chatting a lot. So, Alex, I'm just wondering if you would feel comfortable unmuting your line and sharing with the sort of information that you've been chatting about and seeing how you might begin those conversations about measuring stigma in New Haven and some of the challenges and also some of the things you're kind of hoping to bring back to your community. I think that would be really, if you don't mind.
Sure. Can you hear me?
Hi, sir.
Okay, so yeah, my name is Alex. I've been living with HIV since '86, my test, 30 years. My viral bloom was in 1980 in graduate school, so it makes me a 36-year-old survivor. So I'm a community advocate. I work with the New Haven Mayor's Task Force on AIDS, the New Haven HIV Care Continuum, Connecticut statewide HIV Planning Consortium. And my experience is that people feel very edgy or leery of doing any kind of research, including consumer satisfaction surveys or needs analysis. They just feel inadequately prepared to do them. And the other piece is, even if we can get them to do them, what do they do with the results? So that's the important. Like, if they collect the data, how could they meaningfully use this data? I think we need to sell the Stigma Index as a benefit and also as an intervention tool. That would be my take from this conversation.
Thanks so much. You know, I've seen a couple other notes. Carmen had mentioned, Carmen Madriles had mentioned that this is new for the department, and she'd look into the Stigma Index. You know, and to Carmen and any of the other folks, Sean, Lawana, if you wanted to just share a little bit about what some of your thoughts are in terms of next steps, like how are you going to bring this to the folks who are decision makers in your team to consider these tools? Because, you know, just it's mind-blowing how groundbreaking and important they are.
This is Sean. Can you hear me?
Yeah, hi.
Hi. Well, I'm fairly new in my job, so I have a long list of projects I'm having to look at in terms of like clinical quality, but among other things, but stigma is high on our list, particularly provider stigma in our area. And our doctors or infectious disease specialists are doing primary care, well, partly because of, you know, our clients trust them, but they don't necessarily want to go to anybody else out there, and it's very hard to actually find a primary care provider who might want to deal with issues and having to deal with sexual minorities or people with illnesses. And it's not just the providers, it's often the nursing staff. So these are issues, sort of longer-term issues, when they have to deal with or start dealing with them next year. But I think, you know, talking to clients about stigma may be a good first step for us, because everything I'm getting is anecdotal at this point.
I have a question. Have not seen the index, but could be doing the assessment on a client aggravate their feelings of stigma by going through this process, or would it be helpful?
Great question. Delores, what do you think?
So one of the, that is true, because, yeah, you can always have triggers that triggers the person who you're interviewing. But one of the things we thought about when developing the people living with HIV stigma is that we are asking peers to ask other peers about their experience. And in so doing, you know, there is a camaraderie or an opportunity to share experiences. And while nobody is trained as a counselor and must not take on that role, there is a feeling of person speaking to me understands where I'm coming from. And so as best we can, we try to match peers with peers. And you as well as everybody knows on this phone that even within the HIV population, it's kind of hard to always match peers with peers. And when I'm saying matching peers with peers, I'm talking about, you know, gender line or age line, or, you know, urban versus rural. So we make that effort so that the conversation is between somebody who understands where you're coming from or there's similarity with you. But yeah, we are well aware that triggers might exist, and there are measures put in place to for the interviewer to refer people out, but never to try to counsel.
Important distinction.
I hope that answers your question.
Yes, I think that peers always do help peers. I think that's a great success for peer support groups like Alcoholics Anonymous and NA. And it is a way of getting through to that. And studies show that characteristics of long-term survivors show that they had contact with somebody with previous experience.
Yeah.
That makes sense. It just takes coordination and effort and infrastructure to make that happen.
Yeah.
So I've had a couple of comments during today's discussion, and I also received a couple of emails on the topic too. I'm wondering what folks' thoughts are in terms of how our friends in faith communities can get involved. Faith communities want to see themselves as great instruments of progress and in helping to deal with things like stigma, but we also know that they can also be great propagators of things like stigma. You know, so I'm just wondering, are there roles for other non-traditional HIV groups or entities to participate in this? Just because I know that people are wondering.
Well, you know, Michael, as a first step, sort of beginning to partner and think about the services that we provide in the community in St. Louis and working with our faith-based, you know, community partners and churches. And we had our director of prevention go to the National Conference, which was in St. Louis. It was huge. It was a very big conference, and he was able to presentation of and work with living with HIV who are part of their congregation, and also talking about testing. And so we kind of started a dialogue there that we hope to continue to foster that partnership. But I think that was a huge first step, was being able to present that information at a venue where there's already an audience of people that that are there and that are kind of that willing to dialogue about these issues. So I think that was an important first step in terms of creating a more solidified partnership with that group of people.
Thanks for those comments. Thank you. All right. Well,
that kind of reminds me of that topic we talked about, the perception of the word stigma and what it means. So if you're talking to church leaders, they may think it means the wounds of Christ. That's another definition of stigma.
Yeah, very true. We need to make sure that we're talking apples to apples. So I just want to thank everyone for joining us on today's discussion. There was quite a lot of activity in the chat room today, so I'm going to be really excited to put that together in a Word document for all of you. Everyone who joined today's webinar, your email has been saved, so you'll receive the email probably within 2 hours. That'll include the chat transcript, which I'll clean up for you, and also a link to the recording. You'll also be able to find the recording online directly, and if you pull down the slides, I'll send the slides too. If you pull down the slides and look on the notes page, that's where you're going to find the links to a lot of this stuff that we were talking about and clicking around on slide 6. So please take a look at these resources, and don't hesitate to give a holler if I can help out with any questions, comments, or concerns along the way. And I'm sure Julia and Delores would also be, interested in helping you out too if you have other thoughts or questions or concerns that are more relevant to them. I don't know if Julia and Chep, if you have any parting words for our participants today.
Michael, thank you so much, and all the participants. This is Chat. It was really great listening to all of you. I had a chance to look at some of the questionnaires that had been out there for both for patients and providers, and I think they're really great too. But the question that came from, I think, Alex was like, what do we do once we collect the information? And that is really the quality and the bigger questions. But there are tools out there that can help in collecting data to find out, you know, the degree in which stigma does exist between patients and providers. Thank you so much for this discussion, Michael, and everyone who participated.
Thanks, Jeff. Julia, how about you?
I want to extend a thank you to everyone for, you know, sometimes these office hours, we never know kind of what the day will bring. And I feel like we had a very meaningful discussion today. Thank you for your participation. I mean, Michael and I can talk a lot to each other, but it really is so meaningful to hear from you guys because you're in the field and you're doing the work. And sometimes that's hard work, and I think stigma is one of those things. But I hope that with kind of the introduction of some tools that maybe you haven't seen before, you have some ideas to take back to your leadership to begin to think about how you assess stigma and then kind of move forward in your own work. So I thank you for the journey that you are going to start, and thank you for your time today.
Thank you, everyone. Have a wonderful day and a beautiful weekend. I hope that it's a long weekend for all of you.
Thank you.
Cheers.
Thanks. Good job.
Thank you.